Hi, everybody. I'm Jessica Flanagan, and I am so excited about who I have as my guest today, a colleague and becoming a good friend over the years, Dr. Sarah Zielsdorf. So I want to introduce you, Sarah, and then have you talk a little bit about your practice. But I just want to let everybody know a little bit about who you are and how you practice. Sarah she went to Miami University, which is in Ohio, not Florida. You got a BA in microbiology, a minor in molecular biology and religious studies, and a concentration performance. You also earned an MS in public health, microbiology, and emerging infectious diseases from George Washington University. Oh my gosh, I'm like, my mind is blown already. You got your MD at Loyola University Chicago School of Medicine, and then you completed your residency at Loyola University Medical Center and the Edward Hines Jr. VA Hospital. You're an Institute for Functional Medicine certified practitioner, and you are board certified in internal medicine. So Sarah, you've also been an LDN expert, so you wrote the LDN, the 2020 LDN guide, and you're an author featured in the LDN book, volume 2, published in October 2020. And you have a bustling and amazing practice. So thank you so much for being here. And also just to say the last thing is you work in the Chicagoland area, and you're the owner and the medical director of Motivated Medicine, an innovative consultative medical practice in the western suburbs of Chicago. And by the way, I'm going to put all of your contact information in the show notes. So everything that you share with everybody's, we'll make sure everybody can contact you. Thank you so much for being here. Wow, you studied for a long, long time.
Yeah. Yes.
So tell us about you.
The big joke is always, what grade am I in? My husband's like, are you in 23rd grade, 24th grade now? What grade are you in? So I'm always learning, always studying. My whole life's trajectory really got just, completely derailed, honestly, by illness. And I think anybody that's in the field that I'm in can quite honestly only do this because of their personal experience. Either someone got sick in their family, a very significant other, or themselves, because otherwise it's just too hard. They had to have been touched, especially for me, an allopath, someone who trained as a very traditional MD, to change course so dramatically and even have the flexibility of thought that there could be a different way than one was taught. It has to be something profound. So I always wanted to be an infectious disease doctor. That's why I got my background in what I did. From the time I was in middle school, I wanted to do infectious disease. I wanted to be in the BSL level 4. I wanted to be an EIS officer for the CDC hunting down Ebola. That's what I wanted to do. And my parents...
What touched you? What happened to you that changed your course?
So, I was sick often, in growing up. I had a lot of stuff going on, and I actually was born, I was a preemie, and I had a tracheoesophageal fistula at birth. So I actually I had a very significant operation and surgery. I wasn't supposed to make it. I was pretty small and pretty stubborn. I was a pretty big fighter. So I was in the hospital a while, had some really significant scars, and I had to be in the hospital a lot as a little kid. They actually had to dilate my esophagus. They would, they had to hold me down and give me a barium swallow. For a little kid, that's pretty intense. And I have this distinct memory of being 4 and being, thinking, man, I could do this better. And from that time on, I wanted to be a doctor. I got very interested in microbiology and infectious disease. And so I went through my undergrad. I had an amazing mentor, and I did a lot of research. I thought I was going to be a PhD. Ended up, getting married. But actually in undergrad, I got sick, which was, as we now know, I had a bad viral infection when I actually lived in Pittsburgh for a summer, was doing a pre-med internship, living alone, and I got a virus, and it went to my ear, and I had severe vertigo. And about 6 months later, I had the first symptoms of Hashimoto's, which I had terrible fatigue. I was sleeping 12 hours a day, sleeping during my classes, sleeping after my classes, sleeping through them, and finally got the diagnosis of hypothyroidism, put on the standard of care medicine, but never diagnosed with autoimmunity. Fast forward to medical school. So I had flares, as we now know them, where I'd be sick or I'd have okay periods. But then in medical school, life fell apart completely. And I actually lost a full year. I started medical school with my class. I got so sick that I had to be out for 9 months. And then I restarted, finished medical school, and then started residency. Got sick again, ended up bedbound. It wasn't until being bedbound that I finally fought for a diagnosis and received that diagnosis of Hashimoto's, with I had very poorly controlled hypothyroidism for more than 10 years,
Really?
which led to other conditions. I had pretty significant liver condition, including fibrosis of the liver because of the metabolic changes that happened from the hypothyroidism. And it took me getting that sick to saying, okay, and from my bed, figuring out how I needed to heal. And that is how I changed my course. I was an internal medicine resident, and I then started studying functional medicine, and I worked with different practitioners to, get my life back. I got on the right thyroid medicine for me. I got on the right diet for me. My antibodies went from the tens of thousands to the low 100s. I was told I couldn't have children. When I went back to studying in residency, I found out that I could have children, and surprise, had my daughter. And I flared after my daughter was born, and I had a practitioner put me on low dose naltrexone. And so that was my experience with my first experience. So with all of that, I began training. So right before I graduated from residency, I took my first core functional medicine class.
And so now, isn't that funny how life has a way of guiding us to the places to be? And that now your practice is primarily functional medicine, right?
So I don't like labels. That's the thing. So, and I don't think you do either. So that's the hard part is, I think, because the problem is there are a lot of people that call themselves functional medicine. And yes, I am, and that's a huge sticking issue, especially where I am in the Midwest. We have lots of people calling them this. And this is my big disclaimer. If somebody calls themselves anything, really get to know that practitioner. What is their philosophy? How do they treat? Does it work for you? Don't go to someone just because they have a degree or, what it is. But yes, I do have a certification in functional medicine. I use a lot of tenets of functional medicine, but I use every tool in my box. And a lot of that is, the allopathic traditions that I use, the spiritual traditions that I've learned, the holistic traditions, people who have been in TCM and, traditional Chinese medicine or, Native American medicine, Ayurvedic medicine. There are all of these things that I have learned from my colleagues that I have built and put into my practice or I refer to, because I refer to you, that have helped my patients heal. And that's the big thing, is to figure out what a patient needs, right? And really figuring out what resonates with them. And so if it's functional medicine, I can put that hat on and say, yes, I'm an IFM certified practitioner. Yes, I am.
Does that mean that, I was going to say, do you have a kind of focus? Like, do people who are dealing with thyroid issues seek you out? But it sounds like you have lots of different people. And so our audience, the audience here, is like, if I could just kind of pick your brain on behalf of the big questions that seem to be floating around.
Absolutely.
Of like, how do I even take the first step? They can't even get like a lab panel, a full lab panel from their doctor on thyroid. You are light years ahead of that. And so I'm curious then, let's just start with LDN. You mentioned that. So we know that you are incredibly talented, and have that infectious disease, leaning deep in your bones. And then your mom, you're a medical doctor. You have that certification. You work a lot with, I know, from women with thyroid issues and also other issues, because I often call Hashimoto's the gateway autoimmune illness.
Absolutely.
But you have this really cool thing of you are emerging as one of the biggest LDN experts out there. Talk to me a little bit about how, like, we describe LDN, who goes on it, just say what you want about LDN for
So,
everybody who doesn't know.
so first of all, I consider myself master of nothing. I consider myself a master student. And Neil Peart said that, the drummer of Rush, may he rest in peace. He just passed in January, and I'm a huge Rush fan. And there's so much wisdom in that. And I feel like you are as well. And we're going to get to that when we hopefully get to talking about restrictive diets and where we've both been in our practices. So low dose naltrexone, or LDN, has emerged as one immunomodulatory therapy. And I want to be very clear on that. If I had to put this in a soundbite, the biggest misnomer or misinformation that I see is that low dose naltrexone is an immune booster or an immune stimulator. Okay. I don't believe that, which is why when patients will say, why would we want to give an autoimmune patient an immune stimulator when their immune system maybe is already enhanced in the wrong way, correct? So what is so amazing, just like some of the plants that we use to modulate cortisol, that we call them adrenal support, we do the same with our immune system. And low dose naltrexone is an immunomodulatory agent. It's not taking a drug that is, say, I'm given melatonin, and that is, I'm taking melatonin. Low dose naltrexone, when it is dosed, and when I mean low, I mean usually between 0.5 and 4.5 milligrams. Naltrexone at higher doses, 50 milligrams to 100 milligrams plus, is actually used to block the opioid receptor and is used for patients with addiction, patients with either alcohol or opioid addiction, to help them. And in very, very high doses, it's given in opioid opioid blockade for people with acute intoxication for overdose.
Okay, so I'm going to ask a question that might seem really simple, but who do you consider to put on LDN? And when you do, what kind of things were you seeing clinically that made you so excited about it?
So let me just say what LDN does. So low dose naltrexone, when used appropriately, briefly blocks the opioid receptor for about 4 hours, little bit more, little bit less. Okay. And when it does, you get an increase in your own body's production of beta endorphin and metenkephalin. So beta endorphin can help with mood, with pain, with sleep. And metenkephalins are also known as opioid-derived growth factor. And that has receptors on specific organs, including the thyroid. And so it's not a slow. Yeah. So when you say, who do I give it for? Anything that I need to affect those endpoints. Okay. And I am finding amazing uses for it with my patients with, for instance, small intestinal bacterial overgrowth, or SIBO, because it is an amazing prokinetic. It actually helps the migrating motor complex of the gut.
Oh my God, didn't know that. Okay.
So that's one use of it. I use it for my patients with PTSD, although you have to use different doses, but also with traumatic brain injury, because it helps with the blood-brain barrier and the gut. So, and I use other agents, but I also say that LDN is not a panache. Never use it to believe that this is going to fix all of your problems. Okay. It definitely can work on stubborn antibodies. I often see that, but it takes time. With thyroid, I say that it takes at least 12 months, okay, but true effective LDN can happen up to 18 months. So I usually say, give it a year to a year and a half of a trial before you say, this doesn't work for me. The patients that will benefit most from it and probably have the biggest impact are what I call EOR patients. And I am an EOR. So EORs are people who are glass half empty, who really they tend not to be able to dream. They have a chronically low endorphin state. Patients who have had trauma in childhood often have this. Patients who have, had severe stress or abuse, these are all setups for that. But if you are an EOR, where maybe you don't have clinical depression, but you definitely are just down, you're kind of a down person, glass half empty outlook. To take LDN, I cannot tell you, it was probably the first time that I truly knew what it was like to feel happy.
Wow.
And I just did not have that kind of joy. I had a very flat kind of outlook on things, and it was wow. And my pain had helped so dramatically. And there was a great study of my colleague Dr. Jared Younger. It was featured in 2014 Journal of Rheumatology, which why this is not the standard of care for fibromyalgia patients, I do not know. He found that patients who had an elevated SED rate, which is a marker of acute inflammation,
Yep.
they had the most improvement in their pain scores.
Wow. Okay. So
So
fibromyalgia people, if you have an
yeah.
elevated SED rate, go to your doctor and have another conversation, because fibromyalgia
And
is so debilitating.
so SED rate and CRP. And I have a great colleague, Dr. Ginevra Liptan, I'm plugging her. She's got the Frida Center for Fibromyalgia. She's out in Portland, Oregon area.
Okay.
And she does a lot of work with LDN, but she doesn't just use LDN. It is always in concert with other things. And a lot of fibromyalgia patients are on opiates. And that's really difficult because she knows how to actually dose with both, which is fantastic, because the only reason that you can't take LDN is if you are already on a long-acting opioid, and then certain actual agents like transplant medications, like if you've had an organ transplant, that can be a problem. And then we are using it now with other immunomodulatory agents. So I do want to say one thing. With my work with traumatic brain injury, we know that LDN helps at the level of microglia, which help in the brain. So when microglia are turned on, these are the macrophages of the brain. They eat up inflammation, they eat up badness, right? So when these microglia are chronically activated, if you have an injured open blood-brain barrier, you can't turn them off, and you have a very high risk of neurodegeneration. LDN helps to reset those microglia. So it is profound. So we're using, in general, probably 80 to 90% of my patients who come in are candidates for low dose naltrexone. And it's a conversation, right? A lot of patients are like, no, I don't want to take that. I basically give them my writing, our guides on it, and I let them read about it. Now, I want one last asterisk. I have found that patients tend to flare if they have active yeast overgrowth, Lyme disease, or another underlying problem that needs to be addressed first. It is not the fact that they're reacting necessarily to the LDN. For me, it's actually a really cool thing. If a patient will have a very strong reaction, I say, okay, I started this too fast. Let me really make sure I do this gut work first and see what's going on. And so if a person has a really strong reaction, then I like to say, okay, is there something that was unearthed by the LDN? I don't necessarily believe that it was the LDN driving it.
Okay, I am learning so much. I did not know most of the stuff that you're talking about with LDN. So I'm like, everybody's gonna have to go back and re-listen because you gave so much great information. I want to ask another thing. This is like super high level, the LDN piece. You have somebody like, says, oh, I'm just deciding that I want to take an alternative look, or I want to really look at what root cause might be, or I want to go to my naturopath, or find my alternative medical doctor, whoever it might be. I want to ask them, where should I start? And so I know that this is a very simple question also, but if you had to generalize, what are your favorite tests that you get started with your patients when they're coming in and you're like, okay, we got to start somewhere, so that people might have an understanding of what they might ask their doctors for?
So number one, just even stepping back, if you don't have a clinician, I'm speaking to all of the world, all of your readership, your listenership. If you have a doctor who shuts you down, or a clinician who shuts you down, who isn't listening to you, who doesn't get it, and who says, I'm not running that test, I don't care what you think, stop. Do not even try to talk to them. Do not bring them another article. Do not even ask for anything else. Do not walk, run out of that office, get out of that abusive situation, and find someone who has intellectual honesty, curiosity, a ability to be humble, and to say the magic words to you. The magic clinician, whoever it is, will have the nature to say, I don't know,
Okay.
but I'm listening.
Yeah.
And I'm willing to read and work with you to figure out what's going on. That is what you're looking for. And if once you find that doctor, you say, okay, great. My name is so-and-so, and this is what I've got going on. And it's often a constellation, or what we call syndrome, of symptoms that doesn't have a formal diagnosis.
Yeah.
And you will say, I have heard that these are some of the things that people who do this all the time, and you could totally throw me under the bus. Dr. Zielsdorf does this, for instance. And number one, I take an incredibly thorough history with my patient. I listen to my patient's story, which takes 90 minutes.
Listening.
Period. So that's the number one piece of this, not a test, it's their story. So Dr. William Osler, who's the founder of the American Residency, that jerkbag who basically founded that in the early 1900s, he was the one that basically determined that you had to be an unmarried man to live at the hospital and become house staff to be able to learn medicine.
Okay.
And that's what we're founded on. 100 years later, that's what we do. We're called house staff, and we work 100 hours a week, and that includes nursing moms and, whoever that system hasn't changed. So I'm being, obviously a little, yeah, about it. But what Osler said is, listen to the patient. The patient will tell you what they've got. So the patient will tell you the diagnosis. So once we have that, we do a full set of labs, and I look at, obviously, the basics are the biggest: complete metabolic panel, complete blood count with differential, SED rate, HSCRP, advanced lipids, omega-6 to omega-3 ratio, a complete thyroid evaluation with antibodies, which include TPO and thyroglobulin, anti-nuclear antibody, or ANA, that includes includes titers, and then listed out if you've got other things. If they've got joint pain, I look for markers of rheumatoid arthritis, CCP antibody, rheumatoid factor, vitamin D levels. Homocysteine is critical to look at methylation. Red blood cell magnesium, which is critical. So for mitochondrial functioning, the number one thing I see for a tired patient is a low magnesium level. Magnesium is the number one thing we need. It's actually aside from making ATP, making energy, to make ATP, you require magnesium.
And what's your favorite magnesium supplement?
Depends on the patient. And it depends on if they're constipated, if they have diarrhea, if they've got brain fog, if they've got cardiovascular disease. There are over a dozen forms of magnesium. And so I don't want to generalize, but in general, for people with pain, magnesium glycinate and magnesium glycinate and magnesium malate are going to be the best absorbed. I also am a huge fan of Epsom salts for baths for patients. And if you add baking soda to that, it really helps with opening up those detoxification pathways. Okay. So when I'm under a lot of stress, I sit in a bath and, I think about what's going on. One of my most brilliant patients, actually, because, not a lot of women have a lot of time for themselves. She's like, oh, I just stop up the drain while I'm in the shower and pour some Epsom salt in and let my feet in the pan. I'm like, oh my God, you're a genius.
Yeah, that's
it's great because transdermal absorption of magnesium is pretty good using magnesium chloride.
Wow. Okay.
So there's a lot. And then I get all those tests, and then after we get those back and we figure out if a patient has autoimmunity or other stuff, then we do advanced tests.
Okay. So that's a really important piece, because I'd estimate a pretty large percentage of doctors aren't doing just that basic blood work.
No.
Okay.
No, my patients will come in and they'll get a CBC, a CMP, also iron studies. So you must have a balanced iron and ferritin. I have diagnosed dozens of patients with hemochromatosis, which is an iron storage disorder that can cause death. And it is most often not diagnosed in women until after menopause, because bleeding every month keeps those levels under check. But there's actually a form of it that actually causes problems neurologically instead of just with iron. And it was a patient that taught me that. So
Wow.
it's pretty incredible the more I do. And when you have an iron and a ferritin, which is the storage form, that are mismatched,
Mm-hmm.
you know, that's often a sign of poor methylation. And it's one of the biggest problems I see in my practice. Did you know that you require a level of ferritin of 50 to be able to not lose hair, and a level of 70 to grow hair? And also, we need proper ferritin to be able to make our neurotransmitters. You need proper iron to be able to make dopamine and serotonin. So of course women are going to be depressed.
Yeah. How
Yeah.
often do you see iron lovers, like iron loving bacteria also that, like, do you see a correlation with it being driven up on those lab tests?
We see markers of inflammation. So we will see higher iron, low ferritin in those patients. And patients need to immediately stop taking iron products. And we've talked about this too. You and I think, are one of the few people that, sound the alarm about this. I see a lot of yeast overgrowth, a lot of dysbiosis in the gut, and a sign that there's a real problem. And then we really have to address that. My patients with Lyme disease, I have them not on iron while they are, and it's really hard because their ferritin is often really low. And then in the restoration phase, we get them on the appropriate replacement.
If you could say, when you look at medicine and the version of medicine that you feel aligned with, what do you feel like are the biggest strides that we've made in the last 5 or 6 years? And what do you feel like are the things we really still yet need to work on? Because after that, I want to ask you about women and restricted diets.
I think it's really incredible. I don't know how we're doing on time because I could talk forever. So number one, I think in the past 10 years or so, just being part of this community, having more and more people that are talking to each other in the functional medicine world, we are seeing correlations and sharing more and getting together in these conferences. And then also in the online community, people are coming together and saying, wow, I have that too. I have that too. And we're seeing that synergy, and then light bulbs are going off and we are learning so much more. For instance, I have a lot of people with mast cell activation syndrome in my practice. And I have learned from some of my other clinicians that they're seeing it too. And we are putting correlations between things like Ehlers-Danlos and hypermobility and TMJ and mast cell disorder and thyroid and other autoimmunities and other immunodeficiencies and chronic illnesses, chronic co-infections. And it's this Venn diagram. I could never put that together without seeing thousands of patients. And it's just because I think there was a crop of us that started training and doing this and then being very open and sharing, that we are really seeing and now publishing experiences and case studies. And for me, for instance, with my work with Low Dose Naltrexone, I've treated thousands of patients with LDN now. So I've got that insight, and now having years of follow-up saying, this is what I see, this is what I do, and this is what their labs look like. I've gotten people off of fentanyl patches because of pain. I've gotten people off of immunomodulatory agents, like an RA patient, I've gotten them off of hydroxychloroquine, things like that,
Wow.
and they're taking LDN. So very, very interesting. The other thing is the testing. So 5 or 6 years ago, when you were doing your work and you published your book, and believe me, that was a huge thing for me personally to read your book. And because I had been on AIP for several periods in my life and in my healing journey. And it was incredibly important. About 8 years ago, when Terry Wall, she was 2008, when she 2008, 2009. In 2010, she kind of posted her side-by-side. Terry Walls is an internist who famously got out of her wheelchair with MS. And she is an incredible clinician and researcher. And she has a whole protocol of her diet and also talks about many different complementary approaches, just like I do. Anyway, when she got out of her wheelchair and basically posted her own case study, it was huge for me. And at that time, it was very restricted diet driven. We didn't have the tests to look, at least not reproducible at the level we had. And I'm not saying these tests are wrong. I'm just saying I've moved on from them because as a microbiologist and a really big nerd, I don't know anyone else that's doing things at my specific level in my way. Because I look at the microbiome and I look at these relationships, I don't want to see what can be grown. I want to see at a very sensitive level overall microbiome population. And it hasn't been literally April of 2020 that the test I'm currently using came into another iteration.
Which one?
I am using the Gut Zoomer 3.0 by Vibrant.
Are you? Okay.
And
I've heard that 3.0 is the game changer time.
Okay. Yeah. So they now have taken some of their competitors and they've included them. So I get bile acids, I get short chain fatty acids, I get, if they've got fat malabsorption, I get inflammatory markers like calprotectin, and then I get a wheat zoomer, which goes with it because then I get lipopolysaccharide levels. I can actually now show and prove endotoxemia by the amount of Enterobacteriaceae, which is that gram-negative bacteria population.
Yes.
And what's so cool is, for instance, then I could see if they've got low E. coli strain Neasel in their system. Yeah. That's pretty cool. So then you can see that, then you see that relationship. I mean, this is really nerdy at a very, very high level. Then I get super excited because I can go to the patient and I can say, well, yes, I can say, I don't think the inflammation is in the gut so much. I think it is the fact that you've got a lot of intestinal permeability and your body, because you get secretory IgA, you see that those levels are high, and you see levels of these bacteria. You say an LPS, which is lipopolysaccharide from gram-negative bacteria. That is one of the most inflammatory things the body can see.
Huge, yeah.
Yep. And so we see these patients. I had one today. Her CRP level is constantly 8. She's had 3 echocardiograms. Wow. And also I see levels. So she's got morbid obesity, and she literally has starved herself in her life to lose any weight, been on HCG. She's crying, saying, psychologically, spiritually, I can't do this again. And she's being blamed. She literally, I have on my paper what she eats. She eats 3 ounces of hamburger in the morning. She eats tuna for lunch with vegan mayonnaise. And for dinner, because she can't tolerate salad. And now I know why, because she has maldigestion of vegetables in her protocol. And she eats, barely any dinner. And
by her inflammation's being driven by the endotoxemia from what you see. So it's not her being strong enough. It's not her being restrictive enough. No. It's this thing that's silently lurking, that's driving up all of our inflammatory markers. Because I want to say too, you mentioned Vibrant Wellness Gut Zoomer 3.0. Yeah. That is,
but at the same time, this person had trauma from childhood and intergenerational trauma. She's the daughter or granddaughter of Holocaust survivors, and so we know that plays a huge role in regulation of cortisol as well. There's a lot of work on that. So I don't know if anybody knows about ACE scores, so adverse childhood experience scores, and that plays a lot. But she also has a very disproportionate ratio of Firmicutes to Bacteroidetes. When we see high levels of Firmicutes, this promotes IBS and obesity. She also has almost no underlying bifidobifidum or bifido infantis. That's her start point. And then you put the endotoxemia, her experiences, her longstanding hypothyroidism. She has a leptin level of 80. She's incredibly leptin resistant, and she can't lose weight. And I told her, you can't lose weight. You can't lose weight. And this is not your fault. And today, to actually prove it today is a journey, she told me, of 50 years. 50 years.
Okay, I'm going to tear up. I'm going to tear up, and I'm so excited for your patient who finally sees that it's not about her not trying hard enough.
Mm-hmm. And I think we share that.
So that's the gift that we're getting out of functional medicine is that we're starting to see new labs come forward that prove it's not you and not trying hard enough. And you don't have to restrict the way that you've been restricting when we can take a different viewpoint into all these other factors that can be driving inflammation, like endotoxemia in the gut, which you
And
won't even be aware of.
And I just want to bring into a part a couple of other things. The
Mhm.
other big test, and you and I mean, it's my love language, is the Dutch test, the dried urine test for comprehensive hormones. It has changed. So if you take 100 women, 99 of those 100 will have their life changed by this test in my practice.
Yeah.
So, and I know from taking it myself, this test is not perfect. So you and I both admire, for instance, Dr. Sarahzielsdorf and other big people in this field who will say this test isn't accurate. You need saliva, you need blood, you need this, that, and the other. And I'm in agreement of different things, but pound for pound to tell me pathways of metabolites of all of these hormones.
Yeah.
So cortisol, sex hormones, and methylation. I love this test, and for $250 it is probably the best money that you can spend. And
Yeah.
so I use so let's just say a full panel, a Dutch test, and a gut test as a starting point for having a comprehensive view of what someone is doing. And I want to use one more example real quick. I have a patient, so I just have so many wins this week. I have a 45-year-old who just saw a heartbeat. She had IVF. She had an ectopic pregnancy last year, and she's been dealing with infertility for 6 years now, since she got married. And she is pregnant. She's on thyroid medicine. She's done everything she can, to help her system, and we see pregnancies. I never thought I'd be a fertility doctor, but I've helped hundreds of women have babies because they heal and then their bodies can support a pregnancy. I have another woman who was sexually assaulted. She's 24 years old, and she developed crippling interstitial cystitis and terrible constipation and bloating, and went to allopathic medicine, who offered her obviously nothing but antidepressants. She's over her trauma, but she's just got all of this pain, and she's had a year of pain. And I did her gut test and found her methane predominant SIBO and gave her the papers that show the connection between interstitial cystitis and SIBO, and said, you are not crazy, and here's your lab result, and here's how we're going to treat it. And she hasn't even had her pelvic floor therapy yet. She is 60% better in 1 month after a year of suffering.
Oh my God. Okay.
That's why I do what I do.
That's amazing. This has been incredible. So first is I hope you'll come back, because I know that there's going to be so many questions, and you gave so much great information. Everybody's going to have to listen to it a few times, because you just gave an instruction map for many, many people. Thank you for sharing the tests that you like, because that's the question I get asked all the time. So a comprehensive blood work, we can go through and, put everything in the show notes, and the Vibrant Wellness Gut Zoomer 3.0 and the Dutch test. So Dr. Zielsdorf, how can people get a hold of you? I'm going to put everything, in the show notes as well, links, but tell everybody where we can find you.
We're in the midst of overhauling everything, so our website is very much under construction. It's motivatedmedicine.com. And you're going to know the funniest thing. So last year when I started the practice, I had a generic microbe, a microbe that I selected for my icon. Looks like the coronavirus. So that has to be changed. So, but yes, it's motivatedmedicine.com. Our phone number is 630-492-1965. And basically go to the website. There is a form that you can fill out that you're interested in becoming a patient or want more information. And then staff will respond. It's taking people, we have to be patient. We're all working remotely right now.
So I just want to say that I've always admired you ever since we've met, that you're willing to have a difficult conversation. You're willing to have a different kind of conversation, and that it's so, I appreciate so much that you have let what's happened to you touch you in a way that allows you to love all of your patients. And I know that you truly, truly love all of your patients, and you're highly, highly skilled. And that combination is what people are really looking for in doctors.
Yeah.
And just what you shared here today is going to help so many people. And so I just want to thank you for taking the time, because I know you're one of the busiest people I know, and for inspiring that kind of hope that you are each day and each patient that you interact with. Thank you so much.
Do we have one more minute?
Yeah.
So I want to just talk about real quick about the kind of the crossroads of what you and I do.
Yeah.
So was it 2015 that you came out with the Loving Diet, or 2016,
Yep.
2015?
Mm-hmm.
So I know, because I was starting my practice, and I have this distinct memory of like pre-ordering your book and getting your book and everything, because I was in the AIP world and I was under an ungodly amount of stress in my residency, and how I kind of controlled things was by being AIP after my pregnancy. And it was really significant. And your book really, helped me, and, Sarah Ballantyne's work and a lot of the AIP community. And I know you've gotten a lot of criticism because of your work. And I want to be a little more generic. And I want to say, because, the Dalai Lama talked about this, and he talked about that the goal is not to prove Buddhism right or wrong. He says that basically, if science proves a part of Buddhism wrong, then we have to change Buddhism.
That's really cool.
So I feel like what you and I are doing are not saying, and the hard part is and I've actually asked, I've asked people who I work with in my practice, because they have been AIP, and I said, well, what do you think of, Jessica Flanagan's work and things like that? And I know there was a conversation with me, and, talking about that it can come off to say you are wrong to do this restricted diet, right? Like, we don't want to come off that way. We're not for or against it. As a nutritionist, right? If someone as American goes from the standard American diet and then they go and they eat AIP, right? I mean, that's just eliminating a ton of inflammatory food and just going a long way to increase the nutrient density. That's incredible. And it's just, we don't want people to feel demoralized, say, wow, I did this diet and I'm being told, I'm being shamed, I'm being said that I'm wrong. It's not wrong. And we're not saying that that's wrong. But in my experience, restrictive diets alone are not the cure. And it's just like the Dalai Lama said, we're here to evolve. And that's what I think you're doing. And I think it's so incredibly profound and important to do that and do this work. And that is why I get results, is that I have the humility to say, wow, I did that in 2016. I did that in 2017. And now it's 2020. And I use this test and I'm doing this, that, and the other. And in 2021, I'm going to be doing something different too, because we are just evolving. Now, there is a place for restrictive diets. There is a place for all of these healing diets. And it's incredible. So today, that patient that I told you about, I did her food testing too. And she's literally sensitive to everything she's eating, but she's eating so well. Right?
Yeah.
And I have many patients who react to so many things on AIP, or, back in 2015, we didn't know about histamine intolerance or salicylate intolerance or any of these things. And if you restrict too long in the face of an underlying infection, you will make your immune system react way worse, and you may lose oral tolerance, and it can be very difficult to get that back. Yeah. And you and I share some of the most complicated patients that may be down to one or two foods. Yeah. And it is when you get to a point. So I think the main thing, where you're coming from, and you want to come from a place of love, is say, I don't want to see a person get to that place, right? Instead of saying this diet is wrong, which I think the community has backlashed when you've been talking about this and saying, oh my God, she's attacking our way of doing things.
Because it's not right, it's not wrong. It's actually, there's more.
Yes.
Right. And so that's the kind of conversation that I think there's room for. But when we say there's more, that means that we have to put on a different kind of thinking cap and to serve humanity. Mm-hmm. And so, yeah, thank you for saying that. Thank you.
That's what I wanted to say. And I very much admire your work. And the problem is, and I wanted to bring that out, is that it can be an anti-message, and we don't want to have an anti-message as
Yeah.
well, because anytime you label something like a protocol, right, it becomes a religion, right? And so we don't want militarism, which is why, like, you have a great Facebook site. Can I plug that? So the
Beyond AIP.
Beyond AIP site, which I'm on. And what I love is a person will come on and they will say, I've been AIP for 2 years and, you know, I'm doing really well. And the response is, that's great. Let us know if there's anything you need. Or the person is, I've been AIP for 5 years. I'm really struggling. I'm not healing. And it's welcome. There's a lot of, you know, things that can be done, right?
For the people who are feeling hopeless and nowhere else to go, there needed to be something there to help them because they felt like they had done it wrong.
Mm-hmm.
And so we're also opening up that kind of conversation as well. So, oh, Sarah, will you come back? Can we talk more?
Absolutely. Anytime you want me.
I get ready because a lot of people are going to be contacting you. So, I mean,
and I'm going to want you on my podcast when I get that going too.
Awesome. Thank you so much for being here.
You're so welcome.
I loved it. I learned so much. So, okay. So everybody, you can get a hold of Sarah down. We'll put the links, and thank you so much for being here, Sarah.
Thank you for having me. Thank you so much.
Take care.
Bye.